Well, good evening and welcome to the WPS Jurisdictional J5, J8, GHA Contractor Advisory Committee engagement meeting. Today's date is 2/19/2026, and the time is currently 6:03 p.m. Eastern Time or 5:03 p.m. Central Time. My name is Dr. Denise Nachotsky. I am a WPS Contract Medical Director, and I will be the co-moderator with Dr. Kit Young today for this CAC engagement meeting. My specialty training is cardiology, and I have been a CMD with WPS since 2000, for those who may not have met me previously. It is my privilege right now to introduce Dr. Kit Young. And if you could please, Dr. Young, provide just a brief summary of your specialty training, your state of practice, and your society affiliations, that would be appreciated.
Sure, thank you. My name is Kit Young. It's Christopher, but I go by Kit. And I am the co-chair for the state of Missouri. I'm an anesthesiologist, specifically a cardiac anesthesiologist, which I've been for 30 years now. And I've been the CAC and chair of the Missouri committee for, I'm going to say 10 years, but I'm not sure of that number.
Well, thank you so much for that. And thank you for your dedication and commitment to being a CAC member for us. It is so greatly appreciated. And cardiothoracic surgery, oh yes. I definitely know you for your training in anesthesiology with all the times that I have been in the OR. So yes, thank you for your clinical experience as well as your contributions here as a CAC member. Well, the purpose of the CAC is to, for this open portion of the CAC meeting, is to present the proposed draft LCDs. We have two of them up for consideration this evening, and then thus provide an opportunity for our CAC members tonight to be able to provide feedback regarding these proposed LCDs. We do invite the CAC members in attendance tonight to provide verbal comments or statements to our proposed LCDs. The public is welcome to attend in a listening-only capacity. For disclosure requirements, I must state that your attendance as a CAC member at this meeting implies that you do consent to the public disclosure of your opinion and agree that it may be used and will be clearly identified as your opinion within the proposed or final draft LCDs discussed. If a CAC member does not consent, we'd ask you to please disconnect at this time. This meeting is being recorded and is being transcribed. And at this point now, I will turn it over to my co-chair, Dr. Young.
And Dr. Young, I believe you are on mute again.
Sorry about that. It's force of habit. We've already done the disclosure per the 21st Century CARES Act. So now I would just like to give instructions to the participants to aid in transcription. Before you make any comments, please do like we have done and state your name and whether there are any conflicts of interest, or state that there are none. Individuals wishing to comment may click on the raised hand icon or press *3 if you're attending by phone. When Mr. Staley calls on you, please make sure that your microphone is on at your end and that your speakers are silenced to prevent an echo. CAC members should follow up any verbal comments in writing at the Medicare policy comments at WPSIC.com. That's Medicare policy comments at WPSIC.com. Thank you.
Thank you so much for that, Dr. Young. I'm going to take the next several minutes just to review a few procedural logistics for this open portion of the meeting. For transparency and in accordance with the CMS regulatory guidance, be it the Social Security Act, Section 1862, Section 5D, and the updated IOM PIM, Chapter 13.2.4, Post the Cures Act, all proposed drafts were appropriately posted on the WPS portal. So WPS posted the proposed two drafts on January 29th, 2026. Both of these drafts, the open comment period began on January 29th, 2026, and will run until March 14th, 2026. In accordance with regulatory guidance as well, we have had these LCDs posted on the CMS MCD portal as of January 29th, 2026. So this meeting is being conducted in accordance with these regulatory guidance. Our purpose today is to listen to you. We appreciate and so much value our CAC members. So we typically do not respond to questions or make comments during this portion, but we want to hear from you. So as Dr. Kit Young stated, follow up any of your comments that you may have by submitting to the Medicare Policy Comments at WPSIC.com. When you do, please include the topic of the LCD that you are concerned about or have comments for on the email subject line. Please attach supporting scientific literature in either a PDF or a Word document to your email, because WPS cannot follow email links. All responses are for educational purposes only and do not establish Medicare or WPS policy. All comments from our CAC members will not be addressed individually, but rather they will be compiled and addressed in a response to comment document with the final LCD. So let us begin with our drafts that we have up for today's discussion. The first, for people who are via the phone, and cannot have view to the screen, I will list the LCD and its draft number. Our first proposed LCD draft is DL 40341, and the proposed LCD title is Allergy Diagnostic Testing. This is a new collaborative multi-jurisdictional LCD. The WPS lead CMD is Dr. Joelle Vlahakis, and the primary policy coordinator is Andrea King. Dr. Vlahakis will now provide a brief summary of this proposed LCD, for which she is the lead.
Thank you, Dr. Nachotsky. So allergy testing, this is our companion LCD to our first immunotherapy LCD, and it was written by the same collaborative work group. So it's a multi-MAC collaboration designed to address diagnostic testing specifically. Both immediate IgE mediated hypersensitivity as well as delayed cell-mediated hypersensitivity. It includes guidelines for in vivo testing, such as skin tests, with which most of us are familiar, as well as organ challenge tests. There's serum-specific IgE in vitro testing, and there's also included within this LCD details on limitations and provider qualifications. The writers of this LCD recognize the very important long-term relationships that many allergists have with their patients. And we also recognize the importance of being able to provide diagnostic testing for patients who suffer with conditions that may benefit from immunotherapy. So I'll end there. Thank you.
Well, thank you so much, Dr. Vlahakis, for that very thorough draft summary. Are there any questions from the CMDs on this proposed draft LCD? Oh, again, silence is golden, or I'm too quick with it to say, no, you don't have any. Also, what I would like to take this time just to thank Andrea King for being your collaborative partner here. We often don't, we need to give more credit to our policy coordinators who really work behind the scenes on making sure that deadlines are met, that making sure that we have everything in order. So they are a very instrumental part in LCD development. Is there any comments from the general public on this specific proposed LCD?
Once again, *5 if you are using dial-in. Otherwise, you can click the raised hand icon if you want to make a comment. And I see no raised hands at this time.
Thank you so much, Rich. All right. Our second proposed LCD draft is DL 40343. The title is Computed Tomography Cerebral Perfusion Analysis, or CTP. This is a new proposed LCD. It is an individual local MAC by WPS LCD. The lead CMD is Dr. Juan Shaning Perez, and the primary policy coordinator is Ms. Michelle McCary. And I'm going to let Dr. Shaning, if you could please provide us a summary.
Thank you. So as Dr. Nachowski stated, this is a new LCD. We used to have a limited coverage statement on our Category 3 codes LCD addressing this technology under temporary code 0042T. That code was deleted on January 1 of this year. Reason why we struck out the information regarding our limited coverage from that LCD and decided to develop this new LCD to reinstate that limited coverage that we were expressing in our Category 3 code LCD. This limited coverage LCD also aligns with the existing coverage of 4 other MACs that have published LCDs on this subject matter, that are CGS, NGS, Noridian, and Palmetto. So our limited coverage is as follows. The computed tomographic cerebral perfusion analysis using automated post-processing software algorithmic analysis is reasonable and necessary in patients with acute ischemic stroke caused by unilateral large vessel occlusion in the proximal anterior circulation evaluated at a stroke center. CT cerebral perfusion can be used to aid in the selection for endovascular mechanical thrombectomy if one of the following other conditions is fulfilled. That treatment with the femoral puncture for endovascular mechanical thrombectomy can be started 6 to 24 hours of the last known neurological baseline of the patient and meets the pre-CT cerebral perfusion inclusion criteria as defined by the Dawn trial, or the same criteria, but for doing the mechanical thrombectomy 6 to 16 hours prior after the femoral puncture, when you are following the inclusion criteria of the diffuse trial. The diffuse trial and the Dawn trial were the trials that show that these mechanical thrombectomies were beneficial to the patients selected on those trials when done after 6 hours of the last known baseline. So basically, that's our coverage, and it aligns with the American Heart Association, American Stroke Association guidelines, and the coverage being provided by 4 other MACs and our previous coverage that was being expressed to our LCD on Category 3 codes. So any questions?
Another reminder, *5 or use the raise hand icon.
I believe we do have Dr. Ben. I didn't
Northrop.
catch his last name. Okay, yes.
Northrop.
Hi, yes, can you hear me?
Yes.
Yes, we can. Thank you.
Oh, great. Yes, this is Ben Northrop, CAC representative for diagnostic and interventional radiology from the state of Missouri, like Dr. Young. I just wanted to make a few quick comments on this proposed LCD. We've convened a panel of neuroradiologists and reviewed the evidence on this just to make sure things are as up to date as possible. And looking at some of the more recent evidence from the AHA and the ASA, and I do have those articles, which I will send to you afterwards, and send these comments in writing as well. But it looks like as we kind of summarize the evidence, the treatment window that they recommend now is 4.5 to 24 hours from last known well to selection for IV thrombolysis patients. Those are the ones that are not EVT candidates. And then they favor 6 to 24 hours for those that are EVT candidates. So we recommend just slight tweaks to what you have there on the LCD. The other thing we wanted to mention in the draft LCD, coverage limitations, and let's see, this is the first sentence. It talks about acute ischemic stroke caused by unilateral large vessel occlusion, which certainly there is quite a bit of evidence to support that. However, one thing we thought would be most fitting with the current evidence to add would be medial vessel occlusions. There are a few articles that we have, 3 of them that I will attach also, that says there is evidence that more rapidly and accurately identifying medium and even distal vessel occlusions is supported by multiple studies, both in terms of rapidity of diagnosis and treatment outcomes. So we can send those along to you. Any questions about those potential changes that we're bringing up?
Thank you. The focus of this LCD was, as you noted, we were following the revised 2019 guidelines that the interventions at that time that they recommended were for 6 hours. Previously to that, they will recommend thrombolytics and other interventions without the need of using the CTP, but we will gladly review those recommendations and update any information that needs that on our LCD. So thank you for bringing that up. Please send that by email so we can have that and review that and address that through in our comment period.
Thank you. I will do that.
And I just want to say thank you so much also, because you know what, I just took my recertification cardiovascular board exams. Okay. And yes, I knew that for the 4.5 hours, because that is the most updated guidelines. So yes, if you could pass those along, it would be greatly appreciated. I think I got that question right on my boards now. Okay. Dr. Young, I did see your hand raised at one point. Did you have any comments?
I just had a question. When we're a stroke center and our neuroradiologist routinely doesn't use femoral puncture but uses radial artery puncture, does that make a difference?
We will address that because the way we wrote it femoral punction, but the true intent was from the treatment of mechanical thrombectomy. So if he's doing mechanical thrombectomy through another approach, we can certainly take that into consideration in our LCD. So thank you for bringing that up. Our intent was when it was appropriate to use this technology, at what time after the last known normal of that patient, when before you start the mechanical thrombectomy. So thank you for bringing that's an important point. Please email me that also so we have it on record and we address it on the common response document, because that's a very important point that you brought up, and I'm grateful that you brought that us to our attention.
Yes, thank you so much, Dr. Young. Vitally important, because patients in this population that you may be doing this procedure for in stroke patients, they have significant peripheral atherosclerotic disease everywhere. And multiple times, I can tell you from clinical history that I have had, a femoral approach. You may not have access that way, and thus using an alternate site. And with the catheters that are utilized today, with the great technology that we have, catheter sizes have changed that you can use alternate approaches. So that information was very valuable to us. Thank you.
Any additional questions? So hearing none, and before I pass it again to Dr. Nachowski, please, if you do at some point, have any additional question, you can send them through our email, policy comments@wpsic.com, and we can address them up to the end of the comment period. So if you don't have, if it comes to you later, don't worry, send it by email. So thank you, and your verbal comments today, as I stated, please send it by email, because that's the most effective way of us assuring that we will address them on our common response document. And any reference supporting the new guidelines of 4.5 hours, please send that to us. That's extremely valuable. That's the main reason of this type of meetings, to guarantee that our LCD is up to date with the current practice of medicine. So we really appreciate when you can provide peer review literature that supports an improvement on a document. So thank you. Dr. Nachowski, back to you.
Thank you so much. Okay. If there are no other questions or comments from the public, I believe that my portion is done here, and I'm going to pass it back on to Dr. Kit Young.
Well, thank you. And I believe now we are going to transition to the members only portion of the meeting. So this concludes, unless anybody has any objections. Seeing none, this concludes the presentation and discussion of the draft LCDs. I'd like to thank everybody, the public, for attending, and you may disconnect now. After a moment, we will continue with the CAC members only portion of the meeting, where we will address contractor updates, projects, and provider engagement.